Hello everybody, my name's Ed. I'm Director of Advanced Analysis at NHS England, as Elaine has said. So I've been working on productivity on and off for about 10 years. It's an area I've really found quite interesting to work on, generally from the national perspective. And I'm going to share some thoughts from the national perspective about productivity. Three things key. One is how we conceptually think about productivity in terms of a modelling approach or a paradigm approach. Second off, why this matters for us nationally, the reasons that we are so kind of interested in it. And then thirdly, what this means more in practice at a local level and some of the challenges that we face with measurements and the like. So this is a bit of a, probably you can see it at the back, I hope. I think the slides will be available afterwards. This is our model of thinking about productivity. So we are given a lot of money. There's a lot of investment in the NHS, and we need to translate this money into something of value. That's a big, tricky, complex thing to do, so we split it up into stages. And the stages that we think of is, I've got the money, and I buy stuff. I buy inputs, I buy staff time, drugs, beds, whatever. With these inputs, I arrange them in such a way that I produce some bits of healthcare that are recognisable, outpatient appointments, A&E attendances, and the like. Through putting patients through these bits of healthcare activity, I'm able to generate some sort of good outcomes, better health, and the like. So by breaking this down, we can then start to think about these things individually. The first one is how little can I spend in order to buy the thing? So how can I negotiate with the pharmaceutical companies in order to get drugs pretty cheaply? How can we make sure we're managing things like the agency market where there's a premium on the staff time that we're consuming? And then on that third step down on the effectiveness side, this is probably the hardest bit, is how do we know that we're treating the right patients with the right stuff? We've got things like NICE as an institution here to help us navigate that, as well as various quality metrics or service metrics and the like. And the bit for us in the middle, where we're converting the inputs to the outputs, is productivity. And when we're thinking about how we're measuring this, we're looking at aggregating the outputs, looking at the change over time, aggregating the inputs, looking at the change over time. If the former is bigger than the latter, we've got productivity growth. So a couple of things with this conceptual model. One is the concept is quite simple. The measurement is quite complicated. We find it relatively easy to measure this stuff where we have great data, particularly acutes, inpatients. That's quite easy to measure. It gets harder and harder where we're less confident of the data or the data capture is less. Second thing is that actually, this is quite nice as a model, but all models are wrong and some are useful. This isn't capturing everything that we might care about. This isn't capturing every priority. This doesn't work well or doesn't work naturally well for other objectives we might have, like net zero carbon or the NHS as an anchor institution or health inequalities. So this isn't everything, but it is actually quite a lot for us. Productivity is one of the key drivers, is the key driver, I guess, of GDP. GDP growth is what gives us better living standards. So from a macroeconomic, national perspective, as taxpayers or patients or as a country, we really care about productivity. We also care about the productivity of the NHS specifically because it's a large part of the economy, around 10%, because we are investing into something we want to get the most value out of it as possible, and because the health gains that we will be able to get from NHS care being good would actually free up people maybe who wouldn't be able to work otherwise in order to work, further increasing productivity. So there's a lot of reasons why we care about productivity at the national level. This isn't a new thing. There have been discussions about productivity and targets on productivity for years and years and years. Here at the bottom right, you can see something I nicked from the 5-year forward view. I wasn't involved in the 5-year forward view, but I imagine loads of negotiations went into these numbers. We went back and forth. What's credible? What's ambitious? What's stretching? What's the theory of change? What are the blockers to this? So this isn't new, but some parts of it are new. At the top left, you can see indexes of productivity for the country, for basically the NHS, as healthcare is dominated by the NHS, and for the public sector. Since early 2000s, the NHS has done pretty well in productivity terms. It's generally done better than the whole economy. It's certainly done better than the public sector, but things come crashing down in 2020 as COVID means that we reduce activity and we add more staff to this. So it's quite understandable why productivity has taken such a hit. But this is probably the impetus behind having this session here, because our challenge now is how do we push our productivity up back to the standards that we had before and beyond as well, increasing our productivity growth. And another reason for us discussing this here, I think, is because a lot of the evaluations that we're asked to look at, or sorry, the interventions we're asked to evaluate, a lot of the benefits from my conceptual model that I showed you at the start, a lot of those benefits are related to productivity. I've got some list on the left, I'm not going to go through it in terms of, for the benefit of time. But the productivity sort of it stretches from this fairly esoteric economic idea to this very important billions and billions and billions of pounds national debates issue that we have, to really quite prosaic stuff. People are annoyed by unproductive and unsmooth processes. Both staff and patients don't want to be wasting their time. So there's a golden thread of productivity where it goes from very, very academic to very, very sort of imminent and very important for people. One final point I'm going to touch on. Actually, can I get a time check? 4 minutes, see? Yeah, cool. One final thing is, I've just described how I see this productivity and what I think about it, and how we would in NHS England. Not all of NHS England, lots of NHS England would be discussing this. But the language of productivity is mixed. Some people hear productivity and think, I'm just going to be forced to work harder and harder and harder. Other people might think of productivity as one of those economist things where they know the value of nothing, or the price of nothing. Price of everything, value of nothing, that's the one. A sort of technocratic approach to measuring what's important, which, as I mentioned at the beginning, we're not covering everything here. This isn't a full set of objectives. I mentioned at the start as well about the measure. The measure of productivity that we have doesn't perfectly match up to the concept of productivity we have. Partly this is going to be to do with where we don't have the data. We need to do a lot more work in expanding that. And also, this is to do with where we're doing new innovative things, disruptive technologies and the like, where our old sort of categories of administrative data don't fit what we're trying to do in terms of channel shift or digital things like that. So this is sort of a brief rattle through of where we see productivity from the national perspective. I'm going to hand over to Steve to talk more specifically about the valuation of it. Over to you.
Thanks very much. Hello everyone, nice to see you all. So I'm an academic from the University of Cambridge. I'm an economist by background, and I'm part of the Rapid Service Evaluation team. So I'm thinking about this from a rapid perspective and trying to think about some of the issues. And I guess there's two things that I want to talk about in my few minutes standing in front of you. One is about being realistic about what you can do rapidly. And the second thing is just acknowledging the fact that when you do things rapidly, often what it might do is means you're increasing the extent of uncertainty. And from my point of view as an economist, that's often quite tricky, because often it's quite hard to define thresholds for what's acceptable around point estimates. And then when you're including in uncertainty as well, that kind of doubles the problem. So that's my kind of second main point. So the first thing is, it's just following on from Ed's sort of taxonomy about what productivity might look like. There's just some thinking from me in a very generic sense about the timelines that are often involved in evaluating stuff. So in our rapid service evaluation team, this is the kind of thing we might want to take on board. So we might be, for example, the context might be we're trying to evaluate a new innovation to improve productivity, like, for example, virtual wards, say. And so what we've got is it's just thinking about the stages involved and the timelines involved. So one is we have at T0, that's when the innovation is employed and bedded in. And actually sometimes that's not clearly defined, that's quite tricky. And you might be setting up to do your nice, lovely academic evaluation and things don't quite start when they're supposed to, and that is a bit of an impact. Okay? And then the next thing is, well, actually, to do your evaluation, if, for example, it's evaluating costs and patient outcomes, for example, you need to have sufficient numbers of people to have experienced the innovation to collect the data. So that's going to T1, so that's the kind of the interval A. And then depending on what your outcome measure is, and Ed's already made the point that sometimes that's quite tricky to come up with what the optimal outcome measure might be, you then need to wait for that period to evaluate. So for example, suppose your outcome measure was something like mortality at 90 days or something like that. You've then got that delay as well. And then there's an issue about the time it takes to collect the data and curate it. And then it's the time it takes for the researchers to get hold of that data. And then there's the time it takes to do the evaluation at the end and then to produce the findings. So I guess I'm just thinking here, and this is particularly in the context of prospective evaluation, some of the time issues that are involved. And so often we get asked to do things rapidly, and sometimes it's just simply not possible because particularly some of the events that need to occur early on in this chain. So we can think about how to shorten it, and there's stuff that we can do. I mean, one is, I guess we've all been involved in studies evaluating stuff, and the thing you want to evaluate actually doesn't even start when it was supposed to start, so there's that kind of an issue. As an aside, I'm leading an evaluation of the health and well-being effects of the HS2 train line, and that was a case of it sort of started and finished before we've even got up and running properly. Anyway, but also, I mean, one wants to be kind of parsimonious in thinking, I think, in terms of being very clear in terms of what outcomes and what the data are that needs to be collected and the aims of evaluation. One issue which is actually part of the reasoning behind having the HS and DR rapid evaluation teams, actually in terms of rapid research, the main idea there is actually the rapidity comes in being able to get research teams working on a project quickly. That's one of the potential gains. There's an issue about whether one can look at intermediate rather than intermediate outcome measures in time to try and reduce one of the intervals that I mentioned rather than waiting for longer term outcomes. And obviously one can use secondary data sources. And a big thing which we try and do is to protocolize the analysis so you can get a lot of it done up front. And the last point I just want to make is what I mentioned before about uncertainty. So often, if you do things rapidly, it might be you've got intermediate outcomes. It might be you've not collected as much data as you might like to do. So you can do your analysis and you come up in a quantitative way. You've got a nice point estimate, but you've got a lot of variation around it. You've got very wide confidence intervals. Or from an economics point of view, I like calculating things like incremental cost per quality gained. So I've got a nice point estimate which suggests some degree of precision, but actually is a very wide range around that. And obviously one wants to try and quantify and explore that as much as possible, and you can do that using things like probabilistic analysis, so you can get confidence intervals around your point estimate. And that's like quite neat, and sort of academic health economists like me get really excited about things like cost effectiveness, acceptability curves and confidence ellipses and all that lovely stuff. And it all looks really cool on paper, but the problem is it's really hard to think about how you incorporate that kind of stuff in decision making. So think about, you have an outcome and say, well actually, so you need a particular productivity gain, and you need to exceed this threshold for the intervention to be worthwhile. So you need this idea of a threshold, and obviously that's sometimes quite a tricky thing to come up with. But then it's even more complicated because you've got your point estimate of what the productivity impact is, but that's uncertain, so you've got an interval around it. And so it's almost like not only do you need a threshold for the point estimate, but also for the uncertainty too. So just some thoughts about things to take into account evaluating productivity from an academic perspective in terms of the timelines and also in terms of uncertainty. I'm going to hand over to Will now. Thank you very much.
Thanks, Steve. Good morning, everyone. I'm Will Warburton, so I'm Managing Director of the Shelford Group, which is a collaboration of teaching and research hospitals. Before that, I was a funder and both of improvement programs at the Health Foundation, but also of evaluations that went with them. And my original start into this world was as a health service manager, actually trying to do this. So I've got three insights to follow on, I hope, from Ed and Steve's. One is on how providers think about and interpret productivity, to contrast with that national view. Secondly, some thoughts on time horizons and actually the sort of trade-offs and risks around rapidity. And thirdly, a view on, from my experiences, what I really think does make a difference to people trying to do this at the front line. So firstly, the provider perspective. Well, there isn't a provider perspective. I put some provider perspectives because there are so many. Because when I sit down with the chief nurses of our group, I get a very different response to when I sit down with the chief financial officers. And even within those groups, there are very different responses. It's a deeply complex term that lands very differently with very different people. But when we're running a program within Shelford, I ask people to send me, what do they think this is about? What are they doing? The CFOs were the group that picked it up, and their analysis fits very well with Ed's and think about productivity. They're trying to get more done with the same or less resources as the shorthand for it. But actually, when I looked and asked them to send me their programs, a lot of them are quite really cost containment type programs, and that's the traditional language still within trusts, is very much about cost improvement, cost management, rather than thinking broadly about productivity. And I think it's important, firstly, to acknowledge that wide range of perspectives, and then secondly, to think about when we're evaluating at the right kind of level. Because my second kind of area is short-term horizons and constrained environments can distort what providers end up focusing on. So again, in conversations with colleagues, what came up quite a bit is a lot of nervousness around the idea of investment up front because of the sort of time horizons that people are held to account to tending to be just 1 year, and also costs landing in very different places to where improvements might come. So we used, someone gave me the example in older people's surgery of investing more geriatrician time in multidisciplinary teams up front to have good conversations with patients and shared decision-making leading to lower, less intervention, more conservative management, less surgical regret, but a lot of that showing up down the line, a lot of it showing up in different divisions and different organisations. So I think we need to be careful that we think about time horizons. There's clearly there's a lot of pressure to be rapid, but I think as Stephen's pointed out there in that nice slide, it's about the right moment to assess and evaluate rather than necessarily fetishizing speed over every other dimension. And that takes me on to my third point, which is really the evaluative capacity that I think would be really useful in organisations. And it's interesting, I'm coming into this room, and clearly at the conversation this morning, a lot of this is about well-resourced, thought through, or at least it sounds like it, evaluations of national programmes with theories of change, with expertise in economic evaluation, with expertise in qualitative evaluation. The reality within the provider sector is that where there is that, it's very dispersed, and that most people are making decisions under huge uncertainty all the time. And any reduction in that uncertainty is better than the, I won't say total ignorance because that's too strong a phrase, but the absence of some kind of informed assessment of what we're doing. And I think that takes us into the conversation that was getting in at the end of the last, the opening session, around the balance between your sort of improvement method that's supporting people to improve as they go in very adaptive, fast-moving contexts versus the role of formal evaluation. So in summary, I think there's work to do to move the focus of our kind of organisations onto true productivity gains across pathways and across organisations rather than just pure cost control. I think that we don't want rapid evaluation to drive short-term thinking, of which there is already a great deal. The most helpful evaluation is going to be timely and pertinent. And finally, developing that capacity to improve, for organisations to improve is as important as focusing on whether a particular intervention works. Thanks, Nick.
Thanks very much. I'll just bring that.
Do you want me to, you would like a microphone? Does it come wholesale?
Just,
Yeah.
This was the technical instructions. Thank you very much, all of you. Yes, so I'm just going to, Chair's prerogative, I'll ask you a couple of questions. So following on actually from some of your points, Will, all these interventions in the NHS, they're often in a particular part of the system. but obviously the NHS is not just inpatients, it's not just a ward in inpatients, it's not just a GP surgery. So how do you ensure, and this to Will, but also to all of you, that this intervention that we evaluate takes into account or doesn't have unintended consequences in the wider system?
Shall I make a start and then awesome? So, I mean, I think I mentioned one of the things I had the benefit of learning about when I was at the foundation was I saw the benefit of theory of change types approaches that would try and map this out and get people in a room at the beginning to have that conversation, try and anticipate unintended consequences, come up with evaluation planning. So I think where that's possible, then that's very, very helpful. But the fact is that the reality that coming back into provider world is that the unit of management is just so much narrower and the unit of vision is so much narrower. And the theory of integrated care systems is really promising here, right? I mean, it would be actually, that gives you the opportunity to bring people together to work across the board. The reality remains quite a long way from that in my experience so far. Maybe that others have got different experiences, because organisational imperatives and what people are held to account for still remain very, very much siloed in individual units. So I think that we can see a path to how we could get better at that. And I think we're on that kind of, the journey has begun, but I'd say there's a long way to go until we're actually able to really take account of consequences that are beyond the particular units of organisation that people are set up in right now.
Sure.
Yeah.
I totally agree with that theory of change and integrated care are kind of the key answers there. The only other one I'd maybe mention is I suspect that it is the case that where we don't have the data and we don't have the insight to see what the negative consequences could be, they're much more likely to happen. You know, that stuff is going to get dumped where we can't see things. So expanding, you know, we have a very unequal set of data across the NHS. We've got some sectors very well served, some very, very much not so well served. And so equalising that more, increasing our ability to understand, our ability to understand and also monitor things in other areas, in less well served areas would be a key additional bit, and possibly help with the discussion at the integrated care level, because we'll be, you know, singing from the same hymn sheet. And I guess one of the point on that is where you have the data or where you can have the conversation about the data, thinking through during the intervention or maybe as part of the evaluation, depending on how quickly you're doing it, what are the countermetrics that you want to be paying attention to see, because we never really know if there's going to be the negative consequences, right? We can say them, we can make an argument about them, but having agreed ways of measuring when those things are cropping up to maybe put an intervention on hold or to change up how we're doing it.
I'm not sure I've got much to add other than yes. So obviously one wants to try and think through what the opportunity costs are of a decision, and often think having some kind of logic model underpinning it to think through what the wider implications might be. But yeah, I agree from Will's point of view. The issue is about multi-sectoral costs and benefits are an issue, obviously, where you've got, so for example, you're encouraging GPs to use spirometry to spend more time to better diagnose and manage respiratory problems to try and reduce hospitalisations, but the cost is being incurred here and the savings are going to be incurred here. So you need to try and internalise that somehow, and I guess that's the point around integrated care. But it is a problem because people just think people can't cope with all these multi-sectoral impacts.
Thank you. So yes, often when the NHS introduces a new plan, it comes with productivity targets. The NHS long-term workforce plan is no exception. So it included what might be described as some ambitious targets for increasing labour productivity. What do you think the role might be of rapid evaluation, in particular, of making those achievable? I think I might start with Ed again, actually.
Yeah, so you might. So during on my slides, I noted down a couple of kind of national programs or interventions or things that we've heard of that are being to some extent rolled out or being rolled out and the like. So there's a section of stuff to do with the very ambitious productivity numbers, which will be calculated against that, presumably. Not all of it's going to be nationally directed though, because not all of the productivity stats that I showed you, the index, the growth that I showed you, not all of that was nationally directed, and we couldn't specify like GIRFT contributed this much or whatever else to get to the full amount of productivity that we saw up until 2020. So non-nationally directed productivity gains, which is basically maybe the national way of saying the improvement interventions which we know are going on everywhere. If someone has a good idea and wants to improve a pathway, or is it a better idea of how to do something else in the hospital, are going to be key to realising some of those ambitious targets that we've set. And how are you going to know if you've done it unless you're evaluating it? How are you going to know whether to double down or to spread innovation unless we're able to evaluate it pretty rapidly? And then there's obviously the tension between how quickly you can do it and how well you can do it, and everything else that this conference often talks about.
Well, yes. So I guess the benefit of trying to evaluate the gains rapidly is in terms of being able to judge process and then being nimble about changing what you're doing in the implementation. What I was trying to cover in my slides before, there was actually the feasibility of that in terms of the data. So whether that's feasible to do, I think is a slightly different issue.
The whole service from top to bottom at the moment is facing these huge challenges in terms of these numbers. You'll notice better than me. So 2% of the target, what's the highest productivity that we've tended to achieve in the past?
The average is around one.
It's a sort of doubling of that, and that passes through the whole system. And I think therefore for evaluators, it's interesting to sort of think, what is the tone to strike there in terms of that? Because our chief execs and our CFOs are then passing on an ask into teams which they also know is very, very challenging. They are saying this is possible, it needs to be possible to sustain the NHS. These are all really kind of thoughtful people who are aware that the scale of the asks that's been put on them is really significant. The role of rapid evaluation for me doesn't seem to be to turn up and go, you're not going to do this. You're not doing this. It's really silly.
Yeah.
I'm absolutely caricaturing that. But it's to say, what we are finding is that this looks promising. This looks less so. This is where you can put. This is where, based on the evaluation we're doing, we think it would be helpful to put your efforts. So it's more important about acknowledging that kind of contribution is very valuable, but how it lands could be very different depending on how it's expressed with people, I think. Because people know that these assumptions are very big, but that's kind of the deal that's had to be made to get this kind of investment.
Can I just make another
Yes.
point? Which is that I suppose, because we're thinking about productivity and evaluation, that kind of makes me, and I'm an economist, that kind of makes me think about numbers and evaluating things quantitatively. But of course, there's a rapid evaluation, but that's qualitative as well, and that can be really useful when you're assessing implementation. So, for example, what are the barriers and facilitators to adopting this policy to achieving the gains that we're hoping for? And so I think there is a role there that can be used to help kind of understand some of the issues. So just to flag the benefits of qualitative evaluation as well as quantitative, I suppose.
Just picking up on Will's last point, it seems that productivity in particular, that there's a challenge of language, which I think you alluded to before, in terms of cost containment. What is productivity? Is it cost containment? What else is it? And often you've got different members of parts of the system talking to each other in cross purposes. What do you think might improve that situation? Do you think this is a problem? And what do you think we could do to improve things if it is a problem? I'm going to start with you, Will.
I haven't asked it, do I think it's a problem? Because it invites asking, well, maybe that is not such a problem if people are coming to it with awareness of the fact that people are going to come with different values and backgrounds and interpretations. It becomes a problem when there's an absence of that acknowledgement and it's translated very crudely. And that to me then becomes a conversation which is about leadership and management and how leadership reinterprets these asks and translates them, and then how conversations take place between different parts of the system. So, some will say that the language of getting rid of waste will work better with some people. Sometimes it's very much to try and frame it in terms of more of a goal, a noble goal of sort of continuing to sustain a universally accessible free at a point of need system. It's going to take quite a lot of linguistic agility, probably, from people to be able to translate this into language that will work with different audiences. So it doesn't have to be a problem, but it definitely could be if it lands as, with one of our groups it just started as, the immediate interpretation was this is about staff cuts, and then what about the long-term workforce plan, and it's a defensive shield that comes up straight. We thought we were going to be growing staff, we've been asked to cut them. This is a really tricky thing to get right, don't get me wrong, but I do think that that's the kind of leadership challenge.
I might just ask Ed, do you see this at the national level, or is this something that is kind of most acute at the provider?
Definitely see it at the national level. I think we have, even just within the analytical community, we have people more focused on workforce, or activity and performance, or finance, and they speak slightly different languages, and they use the same words to mean different things, different words to mean the same thing, and there's a lot of work interrelating how one relates to another, which is not exactly the same as what you're talking about, but not a million miles away really. Had a conversation a couple of weeks ago, what is a bed? Because for some people it's very obviously a physical bed.
Yeah.
Some people it's a physical bed and the space to put it in. Some people it includes the staff, some people it includes the consumables. And we're talking about, and some people it is just a capacity unit for the non-elective pathway. So what a bed is, in this one conversation, had so many different meanings, and we're all modelling it and we're all labelling it bed. We need to know, we need to be able to translate across different languages, and I think that's the same thing as what you're talking about, isn't it?
Thank you, Ed, that was great. Okay, so I'm going to open it up to the floor now. So I have a few instructions. So if you feel comfortable, please stand up for kind of purposes of your voice being captured by the recording equipment. And I'm going to take a couple of questions at the time. When you are asking a question, could you please state your name and organisation for the benefit of the panellists? Thank you. So, who would like to ask a question at the back?
Hi, I'm Catherine Faulkner. I'm the consultant public health in the Mental Health Trust, and really recognise that each of the things that you've been talking about in detail, particularly the stuff that Will was saying at the beginning. And I guess I want to bring mental health into the conversation here. And when I'm reading about productivity, it seems that we often are treating productivity, we're thinking about physical health, but mental health is not, we're not really thought at all. And the treatment gap that we have in terms of need and the treatment that we provide for mental health is enormous. And sometimes the most productive thing that we could be doing for society as a whole, the ICS, is investing in more mental health treatment. Yet we are being asked to justify ourselves and cost limitations and constraints. So I would love to have thoughts about how these discussions relate to mental health, because I think they are quite different from yourselves, but also others in the audience, because it is quite, I'm sure there's a lot of experience here, and I'd just love to have a bit of conversation about that.
Great. I'm going to take one more question, but we will make sure that we do answer that. Yes.
Hello, Sarah Stone from the Trust. So I have a little bit cheeky one quick comment, which is from being involved in evaluations in early programs. I think one of the useful things that we did as evaluators is ask people to do a bit of a thought experiment. So if your intervention went absolutely brilliantly and you recruited everybody that was eligible and you had a fantastic impact, actually how much difference would it make to A&E admissions or A&E attendance and elective admissions? And that sometimes is quite helpful because it focuses people on what really is achievable. And then I guess my question is about the point about incentives, and it seems that we've lost a lot of incentives across the system over the last few years for trusts in what they get from managing costs in terms of performance and what you get from improving it, because performance is so way below the national standards now. What benefits you get. So I think it'd be really interesting to hear about whether you think we could do more in terms of incentives.
Okay, thank you. I'm going to start with mental health, which is often forgotten, along with social care. Anyone like to go first?
Sure, happy to. So I think potentially there are two parts to the question you're asking, and maybe, and correct me if I getting this wrong. There's the one part which is we do have plenty of data in mental health, but it's sort of not curated, or it's not as deep. Maybe I'm not quite sure what the right adjective is, but it's not used as much as we use the data from the acute sector. So in terms of productivity, outputs to inputs, we need to agree what those currencies look like, and then we can say, okay, for all we know, mental health might be a phenomenally increasing in productivity sector with relatively flat budgets and increasing activity. You kind of expect that to be the case, as we've seen as we probably will see for analysis on GPs similarly. And there's a sort of a dealing with the sector as it is in terms of its productivity and understanding where are things going well and where are things not so much. The second part, I think, that you were talking about was allocative, which is more to do with actually of all the things that we could do in terms of going to NICE basically. We've got £30,000 to spend. How many qualies can I get from that? And redistribution across the piece. So if that's about NICE, I'll bring Stephen for that, because you've got more of the evaluation side of that. I think the first one is probably the one to start on, because that will open up the question on the second.
I guess one additional thought in my mind is, obviously you're entirely right in terms of accounting for the mental health impacts. I'm kind of responding with a question because I'm just trying to get it clear in my mind whether is it more or less difficult or the same difficulty to do rapid evaluations in the kind of mental health arena. I'm not sure what the answer is, but I guess that's just a thought that springs to mind, is just in terms of the outcomes and the time to effect and that kind of thing. And I wondered if that's an issue coming into play here.
Actually, what I was thinking is potentially for mental health, because it's often younger people, and actually for children as well, where the impacts might be a bit longer term. It can be challenging, I guess, to do rapid evaluation. And I guess what we need to go about against when you're doing rapid evaluation is you've got something very easy to evaluate. I don't know, older people on a ward versus something which is difficult to evaluate, which is an intervention with 7-year-olds to make, getting them diagnosed with ADHD, whatever, earlier, and making sure that the easier evaluation doesn't lead to all the money going towards that.
Yes.
Is tricky.
Exactly.
Is there anything else to add on the mental? I mean, your trusts, they have large mental health.
No, they're predominantly physical, and it's not
it's
an area of expertise. So I can only kind of reinforce that. I think it allies to the point that I was trying to make. My second point when I was that they were really building on their lane, which is the risks of only having those short-term time horizons are very, very real, and it's really interesting coming into. This conference is called a rapid evaluation conference. It's really and all the questions around rapidity. It's really interesting how speed has sort of become such a dominant narrative. I'm not in this world, but to walk in here and hear everyone talking about speed is really interesting, because I think of academics. Sorry, I'm not an academic, so I think all thoughtful, thinking over many years, and sort of building up pictures. And Judith's point around actually both these things are important, informing decision making, but building up a store of knowledge over time that actually moves us forward. I think it's really important to get that balance right. So that's the thought it prompted for me.
Okay, I'm sure people will follow up in the break if they have specific expertise on mental health. So, Sarah, was this a follow-up point to that before I? Yeah. If it was, then if you want to ask, if it was a follow-up,
I'd
yes.
just like to build on the mental health issue.
Yes, please do.
And thinking about what you were saying about cost containment, that's been done at the national level too. I think one of the major constraints on productivity that we're seeing is that range of experience in our staff, from low morale to exhaustion straight through to burnout. And thinking of that as a constraint on the levers that we can pull to increase productivity, that the funding for additional mental health services for our staff post-pandemic finished just over a year ago, and that funding hasn't continued.
over what could we invest in to make the most difference. That's also happening at the national level. So I think that thinking about the size of our levers to change things versus the levers that are coming at us the other way, that's sort of where I was going at with that mental health issue.
Yeah, so you've got mental health of the population and the mental health of staff as well.
Yeah.
Staff, I think that's great, thank you. Sarah Scobie asked a question about incentives in the system, which I think several of you have touched upon.
Sorry.
I'll offer a couple of reflections to get started. I mean, it's a topic that comes up a lot in our group, and clearly it's a system in transition, and there is some nostalgia for the simplicity of the days of payment by results and a very clear link between activity, payment, and then the freedoms that people had then. This is a really, really acute perspective, right, and Foundation Trust perspective. But that people felt that there was a very coherent kind of thing they could tell to clinicians. And over 20 years, that's really, clinical teams really took that on board. You do more work, then there'll be more money, and we'll be able to invest that in your services. It was a simple narrative. It's become a real leadership challenge now to come up with that language of actually, we've still got some of that on elective care, but on emergency, that we need to get into the conversation about admission avoidance, and also system language, as in, if we do have a surplus, that surplus may go to serve the wider population that you're part of, which for a clinician who's very focused in their theatre and just getting through cases is a really different conversation to the one of keep doing more work and more money will follow. So I think there is that has become a lot more complex, and we're feeling our way towards a new leadership language around that.
So I guess I'd just say, I think people and organisations obviously do respond to incentives. There's lots of examples of this in the NHS. The issue for me is sort of the devil's in the detail. So whether there can be perverse incentives, if there's financial incentives, it's there's issues around what the level of those should be and how that's determined. And then there's also transaction costs in terms of the kind of overseeing the system as well, and thinking about potential gaming. So I think they can definitely work, but it's just, like I said, the devil in the detail.
Sure. I think the other thing PBR sort of brought was, I think you probably covered it. It's that level of transparency about what the link is between your income and your costs and the data capture. I've mentioned a couple of times how much better the data we have in the inpatient acute is. That's going to be related to the fact that we paid for this or paid by this, and we've got more detail there. Whereas services like mental health, which are on block contract, haven't had the same rigorous incentive to really get their coding down. I'm not saying they're coding badly or anything, it's just the incentive is not the same for the two. And this has knock-on effects now when we're trying to think through how do we understand mental health services or community services as well as we can, when there hasn't been the same investment in understanding the information that's there. So if you're going to, the incentives that we did have led us to some extent to the data landscape that we see here, which then means that we find it much easier to evaluate stuff in the acute side than in other areas.
I'm noting the time, so I just want to make sure that I've got time for a couple more questions. You say your name, just say thanks.
My name is Devon Elliott from NHS England as well. I'm Head of Evidence and Evaluation for Community Services, so I very much understand what the mental health colleague is talking about, the challenges with block contracts and the fact that you can do more activity but not get paid anymore, unlike in acute services. For me, this is massive, this whole productivity agenda, and I'm in two minds about the word rapid evaluation, because of course we need to know things as soon as possible, but we need good quality evaluation to go alongside all of this. And there were certainly some things from the talks we had earlier that really resonated with me, and there's a question I want to ask. So first and foremost, language. Productivity and efficiency are often batted around, but they're two different things. You define them differently, you measure them differently. So So we have to be very clear on what it is we're talking about and how we measure it. And a lot of these things also then translate down to the data gaps that we have. Some sectors are less well served with this issue. So for me, this rapid evaluation element and how it can help with productivity is going to be a real challenge in those areas where the language is inconsistent, where the data is not up to quality like in other areas, and we need more kind of policy drivers and incentives and all the other stuff we've spoken about. In community services in particular, I guess for me there's also this issue about quality and outcomes, and I'm a nurse by background. So when we're looking at productivity, inputs and outputs, just say your district nursing service, if you have the same number of district nurses doing more contacts or seeing more people, is that better? Is that more productive? And if you look at the numbers, and you see an increase in patients, you'd say yes, okay, this service A is more productive than service B. But how are we weighting these things for quality and for outcomes? If you've got the more productive service having poorer healing rates on their wounds, and these patients are ending up back in hospital with sepsis and other kind of challenges, is that really productive? Is that really efficient? So I guess my question is, how do you account in this thinking for quality and outcomes?
Great. I'm going to take there's one question that I'm going to take two very quick questions. So yes.
I agree with what you said, and just to sum it up for me, I have a real big issue with the term productivity in the NHS and the term product, because we're about people and people are products, and so yeah, I could say loads more, but I'm going to answer someone else. But yes,
I'm going to pass.
I just wanted to follow up on Will's kind of discussion of time horizon and just ask if you have any thinking. I mean, because it's a real barrier, right? I mean, it's a real barrier that people are restricted, and the reality is they will operate within the time frame and within the kind of, legal and organizational constraints. So is there any work on this? What is the thinking? How do you, if you have any thoughts, or the other panel members, about how this issue of the time horizon as you defined it can be addressed?
Okay, so I'm going to say some quick words on measuring outcomes and time horizons. Steve, you look like you want to.
Well, yeah. So I think it's about being upfront about what are the important outcome measures that matter, and it's about, again, being clear that depending on the answer to that question, that might also affect your outcomes. So, in the case that you were saying, it's not just activity. There is an element of impact on health down the line, and that's going to take a long time to. So I think it seems to me about having a kind of upfront conversation about what are the outcome measures that we're interested in evaluating when we measure productivity. I think that's the query. That I also think what you said was exactly right, though. That could have implications for the rapidity, because you might not be able to do things rapidly if it's not just about activity.
Yeah, sure. So there are a number of productivity indices which do weight by quality metrics, and there's some very sort of obvious ones to weight by like readmission rates and the like. I think there's possibly, and we probably don't have time to get into much of the discussion about question about localism and nationalism here, because if we're talking about productivity, we want to look across everywhere. We can't have everyone defining their own quality metrics. At the same time, at the local level, if there's an agreement that this is what we most want to do, that might be something that you do want to incorporate into an evaluation. I think there is something though about, it's not just what the service provider would like quality to be, or indeed an individual patient would like quality to be. It needs to be somehow societal, right? For us to meaningfully interrogate work on productivity.
Okay, I'm going to charge Will with the last word, and you need to cover both quality and time horizons.
My colleagues have spoken well on quality and have expertise in that. I mean, just a great example of the complexity of the language here, and how it needs that translation. Health is a caring profession. It's got a strong humanist tradition. It's about health is co-created between people. And there is a whole school of thought there that dominates many parts of delivery of healthcare, and productivity drops into that like a cold, wet fish. You know, it's just like completely the wrong language, and that's an example of we're going to have to use different language with different people. So I think that just illustrates that really well. On time horizons, I mean, this bedevils sort of public policy and much more widely. I don't have magic solutions. What I do have is that when I sit down with some of our leaders, I am very impressed with those of them that are able to separate out meeting the short-term need versus what they want to do for the patients that they're serving in their organisations in the future. And it's not a satisfying answer to say that it's leadership, because leadership exists in conditions that have to work to short-term time horizons, and people could lose jobs if they don't meet short-term time constraints. But the most impressive leaders that I've come across are those that can hold that longer-term vision for what they're trying to do and take some risk, and are willing to take risk with the support of their boards to do something over a longer-term time frame, knowing and hoping that they will be in that role in 5 years and be grateful for what they've done today, or if they're not, the person that follows them will be. But this is a very complex thing that comes down to sort of many questions about leadership, longevity, our field of vision, the time frames that we think of as a service, and we had a 5-year forward view, we've had a long-term plan. Those have got absolutely battered by short-term events, and hopefully there is, on an optimistic note, if a new government does come in, there'll be an opportunity to get our time horizons at least strategically looking longer again, and then it's up to us as leaders to try and help people to overcome that short-termism, because I don't think we're going to move to 5-year budgets from Treasury tomorrow, or something that's really going to change the nature of that.
Okay, thank you. Thanks all of you. So, fantastic, wide-ranging discussion. I feel like we probably could have spoken for another 45 minutes. There's a I'm going to save you a wrap-up because I think you're probably all hungry by now. But I have some housekeeping notices that I've been instructed to give. The first one is that there is lunch now. And given that it has finally stopped raining, you are able to use the outside space. Please do make use of that. You will have another decision to make because there is another breakout session after lunch, so you need to make that decision in whatever way you made this decision. And thank you very much for your listening and for your participation.